Fine. So we have a really, I think, nice program today. It's a bit more moving to the more complicated aspects of twin pregnancies. So I'm going to talk about TTTS, and I just put this lecture, this picture because of just to show you really the difference between TTTS and TAPS. And it's literally sort of what you see when you do the laser. So stuck baby, and lots of polyhydramnios here. Well, actually, this one, and in fact, one of our fellows have a case, and he's got video of a TAPS, and you see sort of really a very, very pale baby and a very, very red baby. So TTTS, so why does it happen? Well, it happens because there is imbalance across the vascular anastomosis. All monochorionic twin pregnancies do have vascular anastomosis, and there are different types, whether arteriovenous or veno-venous or arterio-arterial anastomosis. But actually, the problem here is that there is an unbalanced blood flow across this anastomosis. And therefore, you have one twin that have polyhydramnios, another twin have oligohydramnios. And in some cases, or in severe cases of TTS, you do have evidence of cardiac compromise. And therefore, polyhydramnios is really the cardinal feature of TTS. If you don't have polyhydramnios, you don't have TTS. And just the presence of oligohydramnios on its own is not really enough to diagnose TTS. And in fact, we saw yesterday from some of the cases that oligohydramnios could be caused by other things, like, for example, renal disorders. And therefore, that causes oligohydramnios in one of the twins. So the diagnosis, as we mentioned yesterday, polyhydramnios, oligohydramnios sequence, and how do you diagnose oligohydramnios? Standard definition: when you have deepest vertical pocket less than 2 centimeters. Well, actually, if you have polyhydramnios, there are different cutoffs. Certainly, in Europe, for example, you have the cutoff of 8 centimeters before 20 weeks, and after 20 weeks, 10 centimeters deepest vertical pocket. And I did mention yesterday that we proposed to have a modified diagnostic criteria for TTS, where when you have the pregnancy or the gestation age less than 18 weeks, that you use a cutoff of 6 centimeters. For the polyhydramnios, and instead of 8 centimeters, and the rationale behind that is the fact that if you look at the reference range for the deepest vertical pocket in monochorionic diamniotic twins, 8 centimeters when it's less than 18 weeks is just too high. And certainly, as I said, almost all of us would have come across cases where you have really clear signs of TTS, including evidence of cardiac compromise, cardiomegaly, abnormal ductus venosus in the recipient, but the deepest vertical pocket never really reaches 8 centimeters at this early gestation age. And we also did mention the Quintero staging, and I guess many of you would know, but just to go through it. So stage 1, when you have the oligohydramnios, polyhydramnios sequence, but you still the donor twin, you can still see the bladder. Stage 2, when the bladder is empty or you don't see it on the scan, despite scanning for a long time, waiting for this bladder to fill. And stage 3, when you start having abnormal Dopplers in either the twin, the donor, or the recipient. And often the donor will have an abnormal umbilical artery Doppler, whether absent or reversed endostolic flow, while the recipient often will have abnormal ductus venosus Doppler, whether high PI or absent or reversed A wave. And then stage 4, so it's more advanced when you have hydrops of one or both babies, and stage 5 when you have intrauterine demise of one of them. And I did mention ISWA guideline that actually they did acknowledge the fact that Quintero staging had limitations. It's not prognostic. The stages are not chronological order. So it's not that TTS starts in stage 1 and progresses to 2, 3. In fact, many cases, the majority of cases of TTS, sometimes the first presentation is already stage 3. But it still remains the commonest classification system that we use. So when should we treat TTS? Well, if you take into account sort of the current evidence that we have and the current reviews and guidelines, we'd say, well, there is evidence that we should treat stage 2 or higher, so 2, 3, 4. And not all stage 1, that there is evidence of definite effectiveness or definite benefit from treatment, but symptomatic stage 1. So if you have, for example, severe polyhydramnios, and this woman is symptomatic. So what are the treatment options? Well, there's always the option of do nothing. Yeah, that's always the option of expectant management, but certainly that's associated with about 80 to 90% mortality rate. There is the option of laser surgery, which is certainly considered as the first-line treatment option in these cases. There's also option of amnio drainage, very simple technique, and in the past, many years ago, that used to be the standard treatment, but certainly that's no longer the standard treatment and is only indicated in special circumstances. And then also there's the option of cord occlusion, particularly in cases where, for example, there is already this cordon anomaly in one of the babies, and then you have TTTS on top, and maybe an option. Or in a very advanced stage, TTS, for example, like stage 4, when one baby is hydropic, and you know that the prognosis of this baby is likely to be poor. There's also the option of termination of the entire pregnancy. It's a very rare option to be chosen by the parents, but in my career, I came across 3 parents who actually chose this option. And you can imagine, so some of them were lawyers, and the possibility of not being able to guarantee a good outcome even with treatment, that was something that they just can't cope with it. Or actually unplanned pregnancy, and for a woman that had 4 children. And actually this is just too much stress and was unplanned, and therefore that was a valid option for her. So there are many studies that compared, including RCT and Cochrane reviews, that compared the option of laser therapy or laser surgery versus amnioreduction in cases of severe TTS, and certainly shows that the overall survival is better in laser compared to amnioreduction. That's valid for both the donor and the recipient survival, and certainly the risk of neurological damage tends to be lower if you use laser compared to amnioreduction. So the survival of one or more was 76% in the laser versus 50% in amnioreduction, and the presence of cystic periventricular leukomalacia was 6% if you do laser versus 14% if you do amnioreduction. And as I said, then there was a number of systematic reviews, include Cochrane reviews, that demonstrating the same thing. So the protocol of doing laser, Monique, I think, will go through that in details. So this is just the protocol that's probably relatively common in many centers in the UK that do laser surgery. And we really do it in different stages. And again, even if you work in a center or your clinic where you don't necessarily offer laser for TTTS, I think it's also important for you to know what's going to happen to this woman, because you are the one who's making the diagnosis. You are the one that's going to tell the woman, look, you're going to go to this hospital, probably going to offer you laser. And often the question, so what does it involve? What I'm going to do, yeah? So, and therefore I think it's still important for you to know. So at least what we tend to do is preoperative assessment, so detailed scan, including detailed echo or heart assessment, because you're looking for abnormalities. You want to determine where is the placenta. The cord insertions, really crucial, and because it's polyhydramnios and the risk of preterm delivery, we tend to measure the cervical length routinely. And then we offer laser for stage 2 or to 4. But as I said, then symptomatic stage 1 TTTS, particularly if you have a short cervix. We tend to do the laser sometimes the same day or next day, so within 24 to 38 hours, and we tend to do it from 16, 17 weeks. So what do we tend to do? This is women, so we take a blood sample for the blood group to determine the rhesus, because she would need an anti-D if she's rhesus negative. As I said, just before the laser, of course, you scan and determine the donor axis, the cord insertion, because that's really crucial to determine where is your entry site, where you're going to put your fetoscopy. Because if you put it in the wrong place and you can't really see the equator properly, that's a really sort of almost failure of the procedure, or that means you're unlikely to be able to complete the procedure properly. We tend to give, or some hospitals, we tend to give through relaxants, and there's different regimes. So some people use endomethacin, 100 milligram PR, or nifedipine. We tend to use GTN batch. Analgesia, of course, we give this woman analgesia, so codidromol, or other types of analgesia. We certainly tend to give them diazepam as well. And then we give antibiotics, usually cefuroxime. The procedure, as I said, we tend to do it in a special room. There are different settings. So I know in Leuven, for example, you do it in theater. Certainly at St. George's, we do it in theater. At King's, you do it in a room. I think in the Dutch, in Netherlands, you do it in theater. Not in labor ward, I've seen it. It was on the same floor as the scans. Anyways, a dedicated room that has all the requirements and the laser. Obviously, you have to be laser certified. So you have to learn the lasers and the safety of the lasers and so on. Of course, you know how to scan, you know how your equipment, how to set up your endoscopy stack, how do you actually set up your fotoscopy. There are different types of laser. You can use either diode laser, usually a 30 to 50 watt, or ND-YAG wavelengths of about 1064, and the power is about 50 to 60 watt. There's different types of fotoscopy. You can have either the 0 degree or the 30 degree or the curved fotoscopy, and that usually depending on the side of the placenta and the equator. The fotoscopy, how big? It's really small. It's about, it varies between 1.6 millimeter to about 2.2 millimeter. So actually the skin incision is usually less than 3 millimeter. It's really small. Of course, we do sterile procedures. At the insertion, as I said, you set up everything, and then you will give local anesthetic. Again, that varies from one center to another. Within majority of our cases, we do it under local anesthetic, so you give 20 ml of 1% lignocaine. But actually, certainly, people do other things as well. So there's some host centers who do spinal anesthesia. In St. George's, where I work, spinal anesthesia is rare. It's only we do it, for example, if we're going to do cord occlusion, or we're expecting difficult procedure, or the woman is very anxious, or, for example, in triplet, and I'm going to show you later, in monochorionic triplet, sometimes we do double entry, and therefore, often in this case, we will use spinal anesthesia. As I said, the skin incision is only about 2 to 3 millimeter, and then you put the fotoscopy under ultrasound guidance. But as I said, I mean, all of this, Monique has got videos, and she's going to go through that in detail. It varies in different centers, but we tend to routinely send amniotic fluid to karyotype, at least for PCR, for trisomy 21, 18, and 13. But certainly if we are suspecting there's atypical presentation or there may be cardiac abnormality, in this case we send an array CGH, so detailed karyotype. And I'm going to show you a case later where we diagnosed abnormalities in the twins. We don't routinely do amnioinfusion, but sometimes, for example, if the visibility is not great or an advanced gestational age, sometimes we do amnioinfusion. The side of the intertwin membranes, once you go in, you want to make sure that you're planning, the scanning and determining where the entry site is correct. And you know that if you can go inside, see the membrane, and actually be able to see the entire equator. So you know that you planned it properly. The laser, we will do the Solomon technique, and we're going to discuss that in detail. And at the end, after we finish, we do amnio drainage. So what about the follow-up after you finish? We do ultrasound to admit the woman just literally for a few hours, maybe about 5 hours, just for monitoring. And then we tend to scan the babies, confirm viability, repeat the Dopplers, and often they will go home the same day. But if you end up by doing the procedure at 8 o'clock in the evening, often they stay overnight. Of course, you have to document everything clearly, particularly which twin is the recipient, which one is the donor, and the cord insertions. Obviously, if it's a patient that she's been referred, we tend to call the referring doctor to let them know how the procedure went, and also discuss with them and agree with them about the follow-up plan. Because a lot of these women will travel long distance to come to the center, and therefore it's much more convenient if they have the follow-up locally or back to their consultant or their doctor. But that can vary, of course, according to different setups. We tend to scan in 1 week until, remember yesterday I said the ISWAG scan weekly for about 2 weeks until the clinical resolution of the polyhydramnios, and then after that every 2 weeks. And the follow-up have to include the middle cerebral artery, big systolic velocity, because you're looking for post-laser taps. Brain MRI, it varies from one center to another, but where I work at St. George's, we tend to offer MRI 28 to 30 weeks for all cases that we do for laser for TTTS. And I'm going to show you some of our data about the brain abnormalities. So back to the ISWA guideline, we said what's the treatment of choice for TTTS? Well, for stage 2 or higher would be the laser surgery. For stage 1, that's not symptomatic and not short cervix, it is okay to do expectant management and monitor because there is no clear evidence from randomized control trial of superiority of the laser over expectant management. What about amnio drainage or amnio reduction? Well, yes, I mean, we had some questions yesterday from the online streaming about, well, there are certain, healthcare settings where that's not available, or the nearest center is miles away and the woman cannot afford, or it's an acute TTTS and very advanced gestation age, and therefore there is still some room for amnio drainage or amnio reduction. We also discussed about, and this is not the ISWAG, this is really the RSVG guidelines, about how do you determine which centers that have the relevant competency and expertise to do the laser, and that was just based on consensus, really, is actually they have at least 15 procedures per year to maintain their competency. So what about stage 1 TTTS? We said that, well, not all the cases need laser, and in fact, not all of them will progress to stage 2 or higher. The progression rate is only about 30%. And as I said, the survival, according to the different options of laser treatment, is not hugely different, but also the data is observational, and therefore there is risk of bias, because certainly the cases that are likely to progress are the ones that are likely to have the intervention and are the ones that are likely to have worse outcome. And I also showed you this yesterday. This is a paper that was published in the American Journal about 2 years ago from North American Fetal Therapy Network, so a group of centers in North America, where they actually published their observational data to actually look at the outcome of stage 1 TTTS and the survival according to the treatment they had. And similar to the meta-analysis that we published that I showed you in the previous slide, the progression was about 30%. Similar to our meta-analysis. But actually what was interesting in this study, that two really messages. Number one, stage 1 TTTS had risk of mortality. It was not a benign disease, and therefore these pregnancies have to be monitored closely. Despite the fact that the progression is only 1 in 3, but it still is at risk of perinatal mortality. The other thing that if you look at this graph on your right-hand side, you will see that the survival, so the red is a double survival, the blue at least 1 survival, compared to no survival, the black. And you see that actually the survival tend to be better in cases when they had amnio reduction or laser compared to the expectant management. And that's the stage 1 TTTS. So the message really from this paper that the fact stage 1 TTTS, we should consider active management. But as I said, this is observational data. This is not a randomized control trial. And there was a multi-center randomized control trial led by Yves Ville in Paris, in France. But certainly there was difficulty in recruitment, and therefore the trial was stopped early. But we don't know the results yet. So should we monitor for TTTS? And the NICE guideline said yes, we should. And in fact, sort of their team from Tampa here and myself, we are members. We sit on the NICE guideline update committee, and we spend long time debating between screening and monitoring. Because what we're doing is we're actually monitoring, is it? You're monitoring for the development of TTTS by measuring the DBIS vertical pocket. While the screening, the concept screening is different. The screening is, for example, the nuchal translucency discordance, whether as a marker to screen or to predict the occurrence of TTTS later in pregnancy. Yeah? And therefore, what we're doing, we're monitoring really for TTTS, we're not screening. So when I said screening yesterday, I don't think it was precise, but it's certainly something that among clinicians, we understand what we mean by that. So we said we monitor for the development of TTTS from 16 weeks, every 2 weeks by measuring the DBIS vertical pocket. And if you have fluid discordance, it depends where you work and it depends on your expertise. You might be more than competent to be able to follow up this woman weekly to look for progression until the diagnosis of TTS, or you might actually refer this woman to tertiary level fetal medicine center where she will be monitored and treated if it happens. And we did say if you have discordance, just see them weekly. So if this woman had a TTS treated by laser, how should we follow up this pregnancy? So weekly for the first 2 weeks, until there is no polyhydramnios. Then after that, the woman goes back to every 2 weeks. And if you have a single intrauterine demise, certainly you should really do brain imaging 4 to 6 weeks later because of the risk of brain abnormalities. And the ISWAC document, we did recommend neurodevelopmental assessment at the age of 2. I'm not sure this is happening in everywhere, certainly in the UK. It's not happening, I don't think so. Gestation age of delivery is controversial, and there's no RCTs to back that up, but certainly common practice based on observational data is that we should deliver these pregnancies at 34 weeks after a course of steroids because of still the residual risk. So what's the outcome? So when you counsel this woman for the laser, we discuss with them the short-term and long-term outcome. And the short-term certainly focus on the survival and the gestational age of delivery, or the risk of preterm delivery. So the double survival is about 60%, but in fact the more recent data suggests even higher than that, so maybe 70, 80% in centers where they have a lot of experience. At least one survival. The old data is 80%, probably the new data is up to 90%. And certainly these pregnancies that are really high risk of preterm delivery, the average gestational age at birth is about 33 weeks. What about the long term? We really need to discuss with the parents the risk of neurodevelopmental problems. So the risk of cerebral palsy is about 7%, neurological impairment about 13%. If you quote 10%, you're probably right. And the studies that was actually done by the German, the Kurt Hecker group, where they actually looked at these babies at the age of 34 months, and they repeated the neurological assessment in the same cohort at the age of 6 years, and they found the incidence of major neurological abnormalities 7% at 34 months, 9% at the age of 6 years. What's interesting that some of the ones that had problems at 34 months, they got better later, and some of the ones that did not have problems actually got worse. Yeah? But it is important, and I think it's really important to actually just tell the parents, even if you don't have a system by which these babies are followed up closely, just by telling the parents, I guess if they are aware and the baby is not achieving developmentally, at least they can actually go to the appropriate clinician or expert to say, look, actually these twins had TTS and maybe this might be related. Because when we started getting the outcomes and the follow-up of these parents, we found that actually a lot of them, that the diagnosis was not made for a long time, despite the parents noticed that there is a problem. It's just because people were not really looking for the potential risk of developmental problem in these twins. So why actually these babies will have neurodevelopmental delay? Well, it could be one of 3 possibilities. Maybe actually the TTS pathology itself that actually causing the problem with the brain development. Well, actually could be the laser, the TTS treatment. Maybe actually the way that you intervene with this shared circulation that could have potential complication. But also the big potential problem is the risk of prematurity. So a lot of these pregnancies tend to be delivered very early, and we know that the probably gestational age of delivery is one of the most important determinant of the risk of long disability. So if you look at the studies in the literature and look at the instance of antenatal brain problems or brain abnormalities, actually it varies according to the management. So in cases that had laser, the incidence is about 5%. In fact, the recent studies maybe even less than that. And in cases that had amni reduction was about 14%. Well, actually the case that had expectant management and the baby survived was about 21%. So you see the incidence of brain abnormalities is higher or differs or lower in the laser treatment. What types of brain abnormalities you see in these babies? Well, they're either ischemic or hemorrhagic. And in fact, even the hemorrhagic lesions, it can happen throughout the pregnancy, for example. While actually the ischemic lesions, it tends to be the type of the ischemic lesion can vary according to the gestational age. So the one before 26, 28 weeks, you could see these abnormalities, while actually after that, there's different types of abnormalities. So why? Why would it happen? What's the pathogenesis? Well, there are theories. We don't know for sure, but certainly there's a series of embolization. If you have TTTS, the two circulations, there's this transfusion, coronary transfusion, and therefore the risk of embolization. There's risk certainly intertwined hemodynamic imbalance, and that can cause obviously changes of hypovolemia, hypervolemia, that can cause ischemia and hypoxia, but it can also cause hemorrhage. So this is when we started doing MRI for these cases. We looked at our initial, obviously we have much more cases now, but just to show you some of the initial experience that we had, and that's why we carried on doing it, because we found that the risk of any brain abnormalities was about 7%, but the risk of major brain abnormalities was about 3%. And in fact, in our data, the major abnormalities that we had was polymicrogyria, bilateral malformation of the cortical development, schizencephaly, ventriculomegaly, and intraventricular hemorrhage. So these cases do happen. It's not just published. And the minor abnormalities was delayed sulcation, mild ventriculomegaly, and choroid fissure cyst. But actually, where I work at St. George's, we agreed that before we tell the parents, we have a multidisciplinary meeting with the neuroradiologist, with the geneticist, with the pediatrician, with the fetal medicine expert, and we agree what would be reported to the parents. So something like these minor abnormalities where you don't really know what the clinical significance for the babies after birth, I'm not sure that you really need to, because the parents, once you tell them the baby have brain abnormality or brain problem, the next step is that, what about the option of termination? Yeah, well, actually, these babies could be completely normal. So causing unnecessary anxiety to these parents is probably not the right thing. If you're a responsible clinician, certainly you will tell them about this, because this is almost certainly associated with risk of disability later in life, but not necessarily about minor abnormalities. Okay, so I'm just going to show you these cases that we had were not the straightforward TTTS cases. So, in fact, the case that had polymicrogyria, this case that had the TTTS was done at 22 weeks. It was diagnosed at 22 weeks, had laser at 22 weeks, and the affected baby was the donor, and the baby had, in fact, persistent cardiomegaly and pericardial effusion even after the laser. It was not getting better. Yeah, so there's not really the straightforward case. The other one that had schizencephaly was 17 weeks. The diagnosis of TTS, so relatively early onset, had the laser at 17 weeks and was complicated by single intrauterine demise of the donor and the recipient in the one that had schizencephaly. And you remember yesterday we said that if there is single intrauterine demise after the laser, there is still risk of brain abnormalities. The third case that had ventriculomegaly and intraventricular hemorrhage, this was a case that again had an early onset TTTS, 16 weeks, had the laser progressed and had the laser at 19 weeks. The baby that was affected was the recipient, and in fact, this case was complicated by post-laser taps. Yeah, and therefore, some centers would say, well, I can't really do an MRI for all these cases. We don't have money. And therefore, perhaps maybe if you want to, you can restrict MRI to the cases that are complicated, not really a straightforward TTTS. So to summarize the brain abnormalities in TTTS, as I said, the more recent data from centers that do laser routinely for TTTS, the incidence is about 2-3%, so consistent with what we found, about 3%. The risk is similar to the donor or the recipient, so both babies or either baby can be affected. The type of brain abnormalities, they can be either ischemic or hemorrhagic. And the risk factors, definitely incomplete laser surgery, so you missed some of the anastomosis, or post-laser taps, or recurrence of the TTTS. So as I mentioned, the brain abnormalities that we had, ventriculomegaly, white matter injury, ischemic lesions, periventricular leukomalacia, interventricular hemorrhage, cerebral atrophy. So these are the abnormalities that you should look for in the follow-up of these cases. The highest risk period of demise after the laser is the first week. 70% of the cases occur in the first week after the laser. And the risk factor for the donor demise, so after the laser, I think the donor have higher risk of demise than the recipient, certainly particularly in cases where they have selective fetal growth restriction with TTTS. Because almost the smaller baby was to some extent dependent on anastomosis, and now you stop this anastomosis, and therefore the donor have higher risk of demise. And the risk factors, if you have abnormalities in the umbilical artery Doppler, so absent or reverse in diastolic flow, if you have large discordance, 30% or more, if you have marginal of ligamentous cord insertion, and if you have many anastomosis that you have to laser during the surgery. And again, mentioned that yesterday, so the risk of brain abnormalities is similar whether the single intrauterine demise occurs after the laser for TTTS or actually spontaneous single intrauterine demise. They both are at risk. So I'm just going to show you a couple of, or some cases that we came across. So this woman, she was 28 years old. First, she had a previous uncomplicated pregnancy, healthy child. The husband was studying medicine in the UK. She had spontaneous monochorionic diamniotic twin pregnancy, and the first scan was at 12 weeks. No problem. And then the next scan was booked at 20 weeks. What do you think? Anyway, so she went her anomaly scan, 20 weeks, and she didn't question because the last pregnancy she had the same, and that was fine. So twin one had a single intrauterine demise, and that was a oligohydramnios with stuck one, and the other baby, alive, twin two, was have polyhydramnios. So this woman obviously was referred urgently to St. George's Hospital where I work, and we confirmed that twin one was demise, was oligohydramnios, and twin two had polyhydramnios. And you remember yesterday we said we will have to do the middle cerebral artery peak systolic velocity, and this baby was very anemic. And therefore, we arranged urgent blood transfusion, intrauterine fetal blood transfusion, and we also discussed the option of doing an MRI in 5 weeks. So she had a transfusion, fine, no problem, and we followed up this pregnancy, and things got better. The polyhydramnios got better, and the baby was fine, and the Doppler is back to normal. So she had the MRI 26 weeks, it was about 5 weeks after the diagnosis of the single intrauterine demise, and this before the MRI, this was a brain, by the way. What do you think? Does it look normal? You see the ventricle, there's a periventricular sort of echogenicity, yeah? So the MRI, this was her MRI, and basically the MRI said, well, there is focal subependymal cystic changes. The MRI did not know the history of the TTTS. What do you need? You should shout. You're too polite. Okay, so can you remind me how to do it, please? Yeah, okay. Oh, lovely, thank you. So there was a focal subependymal cystic changes, and the MRI did not really the background of the TTTS, and therefore they said, oh, it could be infection, it could be white matter injury because of hypoxia. The fishes were lagging 1 to 2 weeks, but that's not unusual to see that in twins where there may be one baby is smaller than the other. And the MRI said, well, we could do a follow-up scan if you want to. This doesn't work. Hold on. I'll be fine, I think. I know what's happening. No. No. The clicker is not. Let me try the computer. No.
Okay.
it's working here, but not moving it here. Okay.
Switch out that.
Lovely, thank you. So anyway, so she had a repeat MRI at about 30 weeks, and this MRI confirmed the periventricular leukomalacia. So evidence of periventricular white matter injury, and which might be associated with a risk of neurological disability. So these parents were counseled, but they were committed to the pregnancy. They said, well, no, I think, we lost already one baby, and this baby is growing and it's okay, so we're not considering the option of termination. And in fact, actually, by the way, we're going to Canada. I said, okay, fine. So I said, well, good luck, and let me know when the baby arrives. And then I get an email from the mom, the woman. She said, oh, the baby arrived, and things are fine, are we okay? And the baby so far is okay. And she feels she's meeting all milestones so far, but we keep an eye on him. But I truly believe he's fine. Okay? This is another case of TTS that's really interesting and was very challenging. This woman, again, she had a previous uncomplicated pregnancy, a healthy child. This one was spontaneous MCDA twin. At 12 weeks, the scan was fine, with low risk for trisomy 21, 18, and 13. At 16 weeks, there was a fluid discordance, amniotic fluid discordance, and size discordance as well. And the twin one the one that had polyhydramnios, had also suspected congenital heart disease. And that was a recipient because it has more fluid. So she had echo the same day at 16 weeks, and that confirmed that this baby had pulmonary stenosis, and this baby also had sinus bradycardia at 16 weeks. So we said, oh, I suspect maybe this baby is not going to make it. I think it's a high chance this baby will die. So anyway, so we said, okay, well, let's look for progression for TTS. So she comes back the next week with full-blown twin transfusion syndrome, and there was no longer bradycardia. The heart rate was back to normal, and therefore we counseled the woman about the laser option, and she went for the laser. So she had the laser, was fine, but after the laser, a few days later, she had rupture of membrane, which is fine. We tend to manage it expectantly, and it does not really behave like rupture of membrane. So I think the risk of infection is not as high, and certainly most of pregnancies will continue. And then had follow-up scans. The TTS got better at 20 weeks. So she was having the follow-up with the cardiologist for the pulmonary stenosis and with us as well. So 20 weeks, the baby, the twin one, the one that was the recipient, had moderate pulmonary stenosis. And twin two, that was twin two. Can you see at the back? What's wrong with that? And it was fixed in this position. It was not moving. It was just like this, hyperextended neck in twin two. So that was the ex-donor. And then we were concerned about the brain, so we did an MRI at 22 weeks. So this is the MRI. You can see this is the two babies there. And so this is the one that had the ex-recipient, the one that had the pulmonary stenosis, and this is the other baby that was the ex-donor that had very, very abnormal posture. So marked hyperextended neck, and the brain was very abnormal, had hypoxic ischemic brain injury, bilateral cerebral malformation. So almost this baby had a stroke, essentially. So what would you do? Well, how would you manage this woman? Just 22 weeks. Yes, you offer selective reduction. That's exactly what we did. So we had a chat about her with her about the selective reduction, but it's not straightforward, is it? Because she's 22 weeks. If you do it at that point, the risk of preterm delivery is really high. And the other baby have the heart abnormality. This baby is almost certain you would need surgery, and therefore you don't really want to have a very premature baby that requiring cardiac surgery. This baby, certainly you really want to do your best to prolong the pregnancy and reduce the risk of prematurity. So the other thing as well with the parents asked, I said, well, if this baby has very abnormal brain, do you think this baby would survive? Do you think what's the chance of this baby not making it, not surviving? And then we questioned, what about the brain stem? Because the brain stem on MRI was normal. So we said, okay, well, maybe we can continue the pregnancy and delay the cord occlusion until later in pregnancy, and we can potentially repeat the MRI later to see whether the brainstem is also affected and what is the chance of this baby dying at birth. So the follow-up scans, twin 1 was fine, the one that have the heart problem, and twin 2, the one that have very abnormal posture and very abnormal brain, started developing polyhydramnios. And why would this baby develop polyhydramnios? Because it's not swallowing. You're absolutely right, and therefore we could not really see the stomach because the baby is not swallowing. And therefore, when you have polyhydramnios, obviously her risk of preterm delivery is also high. So we had to have a really contingency plan. What about if she ruptures a membrane? She's already shrunk, remember, from after the laser. What about if she goes into labor? And then we repeated the MRI to see, because funny enough, I mean, the parents would say, well, maybe actually the baby might die, and therefore we don't need to do any intervention. And she had steroids, of course, because of the risk of preterm delivery. So this is the repeat MRI. You can see this baby is getting worse. And this is the brain. Very abnormal brain, and therefore there was extensive bilateral cerebral cortical malformation, but the brainstem and the cerebellum appear normal, and therefore you cannot guarantee that actually this baby will die at birth. Anyway, so she came back at 32 weeks with severe polyhydramnios, symptomatic, and the stomach obviously was not seen. And therefore, she decided at this point to go for selective for cord occlusion. And in fact, technically, it was relatively straightforward because you see, this is the baby that had polyhydramnios, yes? And you see the cord insertion there, and therefore it was really quite technically straightforward and easy. This was her cervical lens, so we're monitoring her. That was 15 millimeter at that point. So she had the cord occlusion, and a week later, she went into preterm labor, and she had an uncomplicated emergency section, and twin 1 is doing well. The twin 1 had the surgery, had the cardiac surgery, and I saw her as a follow-up and is doing well. So you can see these cases are not really straightforward, are they? So what should we look up for the follow-up for the laser? So cases that had TTS, you send her for the reference center to have a laser, and then after the laser, things were fine, and you're following up this pregnancy. You're seeing her for the rest of the pregnancy. What should you be doing? Well, you need to obviously do the biometry and measure the estimated fetal weight discordance, because you're looking for selective fetal constriction in this pregnancy. You need to measure the amniotic fluid volume because you're looking for recurrence of GTTS. You need to do the Dopplers, umbilical artery, and MCA because you're looking for post-laser taps. And if any of them is abnormal, obviously you do ductus venosus. And funny enough, this slide moved, but actually the picture should be a little bit lower because there is another point which is looking for abnormalities, particularly the brain, the heart, and the limbs. The brain, because I showed you that there is actually the risk of brain abnormalities. The limbs, because of the risk of amniotic band, for example, and there have been some case reports that's published, and whether it's actually because of the TTTS or because of the laser is questionable, likely because of the TTTS in the first place. And then the heart. And the heart, there are obviously a higher risk of congenital heart disease in pregnancies complicated by TTTS, particularly the right ventricular outflow tract obstruction. So pulmonary stenosis and pulmonary atresia is reported in about 10% of the recipients. And therefore, you really need to be looking for the heart as well in the follow-up of these pregnancies. So this is another case. This is the last case I'm going to show you this morning related to TTTS. This is a woman who was a Friday, 28 years old, first pregnancy, had an early miscarriage, had a spontaneous MCDA, and she was having local follow-up every 2 weeks. And also during the follow-up, they noticed that there was a ventricular disproportion, so she had an echo. And the echo, there was no structural abnormality, but they said, oh, maybe the discordant ventricular size maybe actually is related to TTS because she started having amniotic fluid discordance. So on that day, or I think the day before, they actually found that there was a proper stage 3 TTS. So this was a recipient with abnormal ductus venosus. You see the polyhydramnios there. So she was referred to us, St. George's, I say on Friday afternoon. at 24 weeks plus 2 days. You see, it's quite unusual because the baby that the recipient, the polyhydramnios, often the umbilical cord, this is quite actually almost like filamentous cord insertion. Anyway, so she had the laser on Friday evening, and we scanned her. She stayed overnight, and on Saturday morning we scanned her, and there was an intrauterine demise of the ex-donor. But funny enough, the twin two, the Dopplers were completely normal. Even the ductus venosus got better. But this was the heart. What do you think? Discordance, yes. So we did say, look, actually, there's ventricular discordance. And the woman said, oh, I know about it. I've seen already a cardiologist. And they were thinking maybe it's related to the TTTS. They did not find a structure abnormality in the heart. So remember, I told you that we tend to send an amniotic fluid sample for chromosome karyotype or array CGH. And therefore, the result came back, and the result came back as the baby having Williams syndrome. And in fact, Williams syndrome is a genetic problem that's associated with potential risk of disability, mental disability. But interesting, they tend to have supravalvular aortic stenosis. And in fact, if you look at this part, is actually the left ventricle is the one that was smaller than the right ventricle, not the opposite. Anyway, so this woman was counseled by the geneticist, and she could continue the pregnancy. So I mentioned earlier that there are different techniques. The one that's recommended nowadays is a Solomon technique, and that was based in a randomized controlled trial that was published about 4 years ago in the Lancet, where this RCT compared the two different techniques, the Solomon technique versus the old technique, which is a selective laser photocoagulation. So, for example, if you see here, this is a placenta, this is an anastomosis. There's one option, or the old option, was the fact that you just go identify the anastomosis and do laser photocoagulation of this anastomosis. And the Solomon technique was actually, after you do that, you use the laser to draw a line connecting this anastomosis. And this trial showed that actually doing the Solomon was better than doing the selective laser, because it has lower risk of post-laser taps or TTTS recurrence, and also had better outcome. And they had a composite outcome, because obviously if you need to have a very large number of cases. So the composite outcome was perinatal mortality, morbidity, or severe neonatal morbidity. And therefore, the Solomon, based on this trial, the Solomon technique have better outcomes and lower risk of complication compared to the selective technique. So what are the complications of the laser that we need to tell or counsel the parents about? Was obviously the risk of single or double intrauterine demise. With any surgery, there's the risk of bleeding, and the bleeding could be from either the introduction side, from the trocar, or from the placental surface, where they actually went and there's bleeding from there, or when you're actually doing the laser, there's a bleeding from one of the blood vessels. There's obviously the risk of rupture of the membrane after the procedure, risk of amniodehiscence, so you see the amniotic membrane is detached from the placenta. There's iatrogenic monoamniosity, and we saw cases yesterday, Lisbeth was talking about, the fact that sometimes with the laser, you actually create or convert an MCDA to MCMA twin pregnancies, and with any laser, there is risk of infection, of course. Okay, how are we doing with time? I've got a few slides on the TTTS in triplets, which is rare. It's not common, of course, because just the triplets are not common. So yesterday we said that triplets are relatively rare, but obviously with IVF, they're getting more common. So MCTA is 1 in 100,000. TTTS in dichorionic triamniotic triplets, about 10%, which is the same incidence as TTTS in monochorionic triamniotic triplet. But tends to be much more complicated if you have monochorionic triamniotic. So the laser technique itself in dichorionic triplets is the same as in in MCTA twin, for example. So you go inside, you identify the equator, the anastomosis, and you use the laser. And in fact, this is a video that I'm not sure it's going to play, but in fact, I'll leave that to Monique because she's got the video, and she's going to take you through it in detail. With monochorionic triamniotic is more complicated because you have to almost stop the anastomosis between the 3 babies, not just between 2 babies. And therefore, there are 2 options. Option number 1 is actually to do 2 uterine entries. So you're going inside 2 sacs, and in each sac, you identify the anastomosis and coagulate them with a laser. Or the other option is you actually go inside 1 sac, the recipient often, and then use the fetoscopy to go through the intertwin membrane to anastomose or to do the anastomosis with the other twin, with the other 2 babies that you can't see if you are in a sac of 1 baby. And therefore, it's difficult. It's almost like you have to do a Mercedes sign at the end to be able to coagulate the anastomosis between the 3 babies. And therefore, is the survival in monochorionic triamniotic tend to be lower than in dichorionic triamniotic. So TTTS treated by laser in triplet, the survival varies worse if you have monochorionic compared to dichorionic triplet. And also the preterm births tend to be higher in monochorionic triamniotic triplet compared to dichorionic triamniotic triplet. Again, the neurological outcome tend to be worse if you have monochorionic triamniotic compared to dichorionic triamniotic. But the abnormalities is similar to what I showed you before, the one related to TTTS. If you do expectant management in monochorionic triamniotic, triplet pregnancy is complicated by TTTS, the survival is only about 30 to 40%. What about amioreduction? People say, well, the laser is so complicated, actually the survival is less. Can we do just amioreduction, which is a very simple technique? Well, it's not really a permanent solution. You have not really corrected the pathology itself. High risk of mortality and morbidity. Certainly, if one of the triplet dies, there's still the big risk of demise of the or the other triplets or the other twins because the anastomosis are still there. But certainly, some authors advocate the option of serial amioreduction in these cases, but it's not the first line. We discussed that yesterday, that in triplet, you monitor or you screen for TTTS the same as in monochorionic diamniotic twin, from 16 weeks every 2 weeks until the end of the pregnancy. And also, obviously, we're doing the middle cerebral artery peak systolic velocity. Despite the fact there's only very few cases that were reported of TAPS in triplet, very few cases. But if you don't look for it, you probably will not be able to diagnose it until it's very advanced, for example, or until it's too late and this pregnancy comes with intrauterine demise. So again, this data from a meta-analysis that we published where we compared the survival in dichorionic triplet versus monochorionic triplet, I think is useful when you counsel these pregnancies because the pregnancies are not common. Yeah, so you see them maybe every few months, and therefore for me it's useful to have this table because when I'm counseling them, I can quote some figures for the survival and for the risk of preterm delivery and neurological outcome. So really the take-home message, you have to have polyhydramnios to diagnose TTTS. We should monitor all monochorionic pregnancies every 2 weeks from 16 weeks for the development of TTTS. It's a terrible complication because it's associated with risk of perinatal mortality and morbidity, but not just that, there's also risk of heart abnormalities and brain abnormalities. The treatment, as I said, the first line is laser surgery, the Solomon technique. The evidence is there between 16 and 26 weeks, but even the pregnancies that present before or after, is still many centers will still advocate laser as a first option. Okay, question? You look stunned. Yeah, Shen.
If you had DCTA triplets and you had stage 4 at 27 weeks, all 3 babies are good sizes, would you consider laser, selective reduction or delivery? So
say it again, so a triplet?
Stage 4, so hydropic recipient.
In dichorionic triplet?
Yeah. So would you consider delivery if they're all 3 good sizes, or would you consider
And
laser?
how many weeks again? Sorry.
27 weeks.
27?
Yeah.
Well, I will give steroids first of all, and then I'll sit down and have a discussion whether and also take into account the technical. So where is this placenta? Is it anterior? Is it posterior? What's this woman's history? But certainly, if it's a hydropic, the options would be between cord occlusion and laser. I don't think there's harm in trying laser. Kurt, yes, behind you.
Laser, definitely laser.
Yeah.
If you take out the hydropic recipient at 27 weeks, the prognosis is very poor.
Will die. Yeah.
Any more questions?
Any more questions from the floor? Come on, we want challenging questions, challenging cases. Let's create good discussion like yesterday. Okay, Kurt, please. Yes, sure.
I have a question regarding the case you showed us
Yes.
with the hyperextended neck. Couldn't you have done just a potassium chloride injection because you have done a successful laser before? So I wouldn't go for a cord coagulation.
Yes, and yesterday when we had the talk of the selective reduction, I showed you there were 3 cases. It was published by Quintero, was co-author, where they actually reported use of KCL in these cases after laser. But what about if we missed anastomosis or if there was recanalization?
I wouldn't worry about that. We have done it, and I mean, there are much more cases which have not been published because nobody is going to publish it anymore, I think, and no journal is going to accept it as a case report. And it's quite safe to inject potassium chloride, and it's much less invasive than doing a cord occlusion. If you are happy with your laser, do it.
Okay, that's it's a very good suggestion. So in this case, it's much easier.
What about doing radiofrequency ablation? Because then at least you don't have the risk of embolization of the potassium chloride towards the healthy twin. Because I'm a little bit worried. I mean, it would be like a disaster, and it will definitely not be published if it happens that the healthy. I'm not sure.
But the radiofrequency ablation, I mean, we didn't really have good experience with radiofrequency ablation. It's not my favorite option, and in fact, I thought maybe it's maybe because we just have a new experience with. But last time we did the course, Yves was here, and he was actually saying the same thing. He had really bad experience with radiofrequency ablation.
But not after laser. I mean, if they're separated, it's just a feticide, right? Then
Okay, so it's just technically easier to do it. Okay, that's a good option. What do you think, Kurt?
I've never done it. We don't even have the device for it.
Yeah, we bought. We got the device and we tried it, and I really don't think it was a good experience.
We have
I think a lot of
never-
this baby, a lot of the co-twin died after that. And I don't know, maybe it's just not controlled, maybe, I'm not sure. But I said that, the fact that I've heard from other very experts in the area having similar experience, I said, okay, well, it's not just us.
but China and Canada have very good experience with it.
Who? You did?
Sorry. So in China and Canada, I mean, there in the literature there are large series of use of radiofrequency. I think it's I mean, especially after laser surgery, I wouldn't be worried about using radiofrequency. Yeah.
Okay. Monique?
Yeah, I agree with Kurt. We did some KCL as
After the
well,
laser.
and that went well. And cord occlusion can be difficult in these cases as well because the cord gets too thick to fit into the bipolar device.
Yeah.
So, and we in Leiden have relatively good experience with RFI, but I will show that later.
Okay, perfect. That's great. Thank you. Any other questions? Should we ask the people from here while Monique, do you want to come and set up your...
This one and this one. This two.
Okay, so good morning from London. So for the online stream, good morning. Is there any advantage of doing laser in stage 1 as prevention strategy for TTTS? Is the progression always from stage 1 to 4 order? Okay, well, with the second question is that it's not always from stage 1 to 4 in order. Sometimes they just progress from stage 1 to stage 3 straight away. Your question is about, the other one was about whether doing laser as preventative strategy. I'm not sure sort of preventative strategy is the way I would describe it. I'd say probably just treating stage 1 TTS. Some people would just treat it as a first-line treatment, and some people would treat it if there is progression or the polyhydramnios become severe. And I said I showed you the data, and I think the practice varies from one center to another. I think some people would just use a laser as the first line. It'd be nice to share the experience. So what do you do, Kurt and Lisbeth and Monique? And other people as well. Do you offer laser as first line for stage 1? Or do you wait for progression? Depends on what? You need to talk on the microphone.
So it depends on the cervical length. It depends on the woman if she's symptomatic. If it's really like an anhydramnios in the donor baby, then I tend to do laser more as a first line treatment.
Okay, good.
I think there's no major difference between stage 1 and stage 2. It's just a function of the bladder, which in most of the cases is a very tiny, small bladder anyway, and there is no dynamics behind it. So for me, stage 1 and stage 2 are the same. It's an arbitrary definition or differentiation. And if you have severe polyhydramnios and anhydramnios, or a pocket less than 2 centimeters in the other one, well, what are you going to gain by waiting?
Yeah.
I mean, do the laser. Yeah.
Which is certainly is consistent with the new data that's been published, and the one I showed you in the North American fetal therapy, we actually say, well, laser is better in these cases.
We tend to wait just before we randomized for Eve's trial, and we tend to wait, but in some cases it goes away, but in a lot of cases you extend the period until it becomes 2, or suddenly it is 3. And I think the data of our center show that a prolonged waiting of stage 1, for instance, increases your risk of pulmonary stenosis, that we saw in several cases. So I agree. If you have a technical case which is technical feasible, I would advocate of
so you
treating. But we are awaiting Eve's results, and then I think we have enough evidence.
And you have a high risk of rupture of the membranes.
Yeah. Going into labor.
And you even have cases where you have sudden intrauterine fetal death at stage 1.
Yeah.
So for me, there are only 3 stages anymore, which is 1 or whatever. Let's call it 2. 2 becomes 1.
Yeah.
3 becomes 2. Severely abnormal Doppler, and then high drops. And 5 is useless anyway because 1 is dead.
There's no point in doing it. Yeah.
You're too late.
I even did a laser last Thursday, which was, according to the staging criteria, not a stage 1, with one deepest pocket of 12, but the other had 3. Yeah. And we waited for a long time because it was not even 1, but the baby had, at the end, cardiac decompensation. Yeah. So we treated her.
But then actually,
and then you
3 already.
Exactly.
And cardiac findings are trump.
But because we still treat it in a consecutive way, so that's difficult. We should reconsider the staging system.
Okay, that's great.
Can I just ask a question?
Yeah, and
it's really good to hear that stage 1 and stage 2 don't exist, because I hardly ever see any stage 2s. It's either stage 1 or it's stage 3, and stage 2 is almost arbitrary. But when you say about early intervention with laser, are there other factors that you consider? So, for instance, if you've got stage 1, whatever we call it, at 16, 17 weeks, that's probably more important than if it's developing at 26 weeks in your approach to whether you would laser, because we know that some will resolve and some will progress. So does that influence your decision making?
Yes.
So the question is, the earlier...
Yes, of course, yes.
If it is earlier, I think your threshold for treatment is lower.
I mean, particularly, look, if a woman who's, very high BMI, as anterior placenta, and stage 1 TTS with a discordance is not symptomatic, the cervix is not large, it's not very short. I mean, I think some people would say, well, maybe we just wait because, technically it would be quite tricky with this 100-kilo woman.
I would wait for another reason, which is with a completely thick anterior placenta, I would wait.
It's difficult.
You get more amniotic fluid, and then it's easier, and the chances to be successful in coagulating all the vessels along the vascular equator is much higher than if you do it too early.
Yeah.
And I would rather accept that something happens between week 16 or 18, which is unlikely, really, and you wait for better conditions for laser.
Yeah, perfect. I agree. Lisbeth?
Yeah, also these early interventions, I think if you can gain like 1 or 2 weeks, it's important for the risk of PROM. I don't know your experience, but I mean, the weight, I mean, it's been also demonstrated in the literature that the rate of rupturing the membranes is quite high when you do surgery at 16 weeks.
Yeah, you're absolutely right. So the Canadian data, they did report that the outcomes were similar, even if you do it before 17 weeks or after 26 weeks, but the rate of rupture of membrane was higher when you do the laser before 17 weeks.
And also single demise after laser is higher in the very early cases.
Yes. Yeah.
But that's probably also because they are more sick.
They're more severe.
The early
Yeah.
onset, yeah.
French study, Julien Stilnemann
Yeah.
as well. Rupture of membranes is significantly higher if you do the laser before 17 weeks.
Yes, indeed. So in our center, we try to avoid doing it before 17 weeks. We try. So if they come at 16 weeks, sometimes just waiting 1 week just to get to the 17 weeks. Okay, any other question? I think we answered all the questions on the online stream. Okay, great. So we'll move on to the